I'm Dr. Gregory Martin, the Chief of Tropical Medicine and Infectious Diseases in the Office of Medical Services at the U.S. Department of State. And I'm here with Dr. Barry Simon, the Medical Director of the Peace Corps Office of Medical Services, to discuss some of the concerns you may have about malaria prevention during your upcoming assignment.
Every year, the U.S. government sends thousands of its employees and volunteers overseas for periods from a few days to a few years. Among the many rewards and challenges of life overseas are threats to our health, from air pollution and traffic accidents to diarrhea and tuberculosis. Today, we want to address one of the most serious and potentially deadly threats to you and your family while living abroad: malaria. Just in the year 2013, the State Department had 49 cases of malaria at overseas missions, and Peace Corps had 113 confirmed cases among volunteers. Most of these cases occurred at African posts. These malaria rates are well in excess of those among American tourists and the U.S. military, and uniformly occurred in those who were not consistently using their prophylaxis. Nearly every government agency with staff in the tropics has had cases of serious illness or death from malaria among volunteers, employees, their spouses, and children. Tragically, in some cases, those stricken have been even working on U.S.-sponsored malaria eradication programs in their host nation. They became one of the 660,000 people per year who die from this preventable disease.
Whether this is your first assignment to a malarious area or you have spent decades in the tropics, you likely have heard something about the prevention measures recommended. Some of the conventional wisdom is true, some of it is partially true, and some of it is completely false. Media discussions regarding malaria prevention are too often one-sided and full of inaccuracies, often serving to only confuse and scare people regarding their options. Our goal today is to examine some of the issues that have been raised by Peace Corps volunteers and State Department employees on malaria surveys performed in 2013. Our agencies co-hosted a meeting with the Centers for Disease Control Malaria Branch in December 2013 to review and discuss some of the unique concerns raised by those who will be spending years in malarious areas and will be recommended to use topical repellents, treated bed nets, and malaria medication throughout their assignments.
In addition to Paul Arguin, the chief of the CDC's Domestic Malaria Unit, discussing the science behind the malaria recommendations, we wanted to introduce you to some of our Peace Corps and State Department colleagues who have directly faced the consequences of malaria. Each of these cases occurred during 2013, and the individuals interviewed volunteered to participate because they felt strongly that you might benefit from their experiences and prevent you or your family from suffering a malaria tragedy.
I love to talk about my daughter, Danielle. Danielle decided to join the Peace Corps when she was a junior at Brown University. I was a little bit surprised because Danielle was a typical only child who was overindulged. Even when she said Peace Corps, I said to her, "Peace Corps, Danielle, really? No Starbucks, no nail salons. You do understand Peace Corps?" And she said, "Yes, Mother." Danielle had spent 22 months as a Peace Corps volunteer in a village or community in Ghana. She was a health volunteer. She really focused on HIV and malaria.
On April 28, 2013, while completing the last months of a highly successful Peace Corps tour, Danielle Dunlap became ill and died from malaria while being transported to a hospital. She was 25 years old.
How had I sent a healthy, intelligent, and vibrant child, young woman, to be a public servant, and I was going to get on a plane within the next 12 hours, go to Ghana, and bring her back in a flag-draped coffin?
Danielle was just one of over 216 million worldwide cases of malaria reported each year. Malaria is a parasite transmitted from the bite of an infected mosquito. After at least a week of incubating in a person's liver, the parasite bursts out into the bloodstream and starts infecting red blood cells.
When symptoms first start, a person will develop fevers, shivering, shaking, chills, sweats. They feel miserable. In some cases, malaria can be treated promptly, and the symptoms won't progress. If treatment is not started right away, the malaria parasites will continue to reproduce in the body. Symptoms will continue to progress. Different organs will start to get affected. The brain, the lungs, the kidneys, they'll start to shut down, and the patient develops severe malaria. This can result in permanent disability or death if not treated promptly.
Malaria is mainly in the tropical latitudes, primarily in sub-Saharan Africa, South Asia, and the tropical Americas. In much of the world, malaria has been a scourge throughout recorded history and continues to kill hundreds of thousands of people annually, but it is imminently preventable and curable.
There are two key components to malaria prevention. It includes, one is chemoprophylaxis, or taking a medicine to prevent malaria. The other part is to avoid mosquito bites, and there are several ways this can be done. It's important to wear an insect repellent if you're going to be spending time out of doors in the evenings. In addition, if you are staying in an open-air accommodation, an insecticide-treated bed net is a proven way of preventing malaria. A bed net provides a barrier between you and the mosquitoes. The fact that the bed net is insecticide-treated will both kill mosquitoes that happen to land on it and then also repel mosquitoes, preventing them from coming into the room in the first place.
In a 2013 survey of Department of State employees assigned to malarious areas, 22% of those surveyed stated that they don't take any anti-malaria medications. Others who initially were taking antimalarials elected to stop taking their malaria medication based on the advice of neighbors, colleagues, and local friends. Corporal Hellam, the Marine security guard you will be meeting shortly, was going TDY to Tanzania, an area where the medical provider recommended antimalarials throughout his stay and for 4 weeks after returning to his post in Antananarivo, where State Department personnel are not recommended to take chemoprophylaxis.
In June, July of 2013, I was called up to go off on a POTUS visit to go off to Dar es Salaam, Tanzania. So I went off to Tanzania for about two to 2.5 weeks. When I got there, I asked the Marines that were in Dar es Salaam, I asked them, do we need to take our doxycycline? They said, no, you don't need to take your doxycycline. You're in the middle of the city. You don't have to worry about it. And if you go outside of the city, then maybe take it, but otherwise you don't have to take it. Now, I did take it just because I wanted to be on the safe side. I took it a few days before I got there, and I took it the entire time I was in Dar es Salaam. But again, everybody said, don't worry about it. It's not that big of a deal. So when I got back to Madagascar, I said, all right, yeah, I don't really care all that much. Fine, I'll just put them away. It was about a week later, after I got back to Madagascar, that I started feeling pretty sick.
A few days after he started feeling ill in Tana, Corporal Hellam was diagnosed with malaria and medevaced to South Africa. The next morning, his malaria-filled spleen ruptured, and 3/4 of his blood poured into his abdomen. He lost consciousness, had a cardiac arrest, and required 10 minutes of cardiopulmonary resuscitation before he went emergently to the operating room, where his spleen was removed. His lungs and kidneys failed, and he subsequently spent over a week on mechanical ventilation and a kidney dialysis machine.
What they had told me was I pretty much almost clinically, technically died because there was no blood pressure, nothing going up to my brain, nothing going anywhere. And they said that my heart was just kind of pumping on reflex. They thought I was going to be like, a vegetable for the rest of my life because of the lack of blood and oxygen that had gotten up to my brain.
Mefloquine, doxycycline, malarone, and chloroquine are the 4 most prescribed antimalarial medications. A decision on which medication to be used is based on a discussion with you and your provider. All medications have some side effects, but our surveys demonstrate that it is the fear of these side effects, not actually experiencing side effects, that leads many people to choose not to take their malaria prophylaxis.
There's no question. The risk of malaria, if you are posted in a malaria endemic area, is much higher than any risks associated with medicines. All medicines have side effects, including antimalarial drugs. However, most of the medicines that are available for chemoprophylaxis for malaria are extremely well tolerated and very effective at preventing malaria. If you are one of the 10% or so of people who develop side effects, you can switch to one of the other chemoprophylactic options.
One frequently cited piece of, quote, conventional wisdom is that since malaria starts as a flu-like illness, a person can just start getting treatment as soon as they become ill and avoid the need for prophylaxis. This strategy, frequently recommended by European doctors, is effective for many people, especially in low-threat settings, but is potentially very dangerous, particularly in high-risk locations. Additionally, in some malaria cases, the infection becomes overwhelming so quickly that serious complications or death can occur, even in those who are promptly treated and medevaced. Our next interview is with Abby, a Foreign Service officer stationed in Bamako, who chose not to use prophylaxis despite repeated cajoling from the regional medical officer.
Part of my social circle was a European, Middle Eastern kind of expat community. And we all hung out, got along very well, and they had been living there all their lives, and they never took it. And they thought it was crazy that Americans would take malaria medication. And they told me, oh, if you get malaria, you just go down to the pharmacy and just grab some medication, and it's not a big deal. And oh, actually, yeah, the more you get malaria, it's just kind of like the flu. And I remember seeing people and being like, oh, where's so-and-so? Why isn't he at the party? Oh, he has malaria. And it's like, oh, okay, well, we'll meet him for lunch tomorrow, kind of thing. And that was the attitude everybody had about it. So it was so hard, actually. I felt bad for the doc at Embassy because he was doing all that he could to raise awareness, and he had the ambassador write an email about her experiences with malaria, and he couldn't do anything to counter what we were seeing socially, which was malaria is not that big of a deal.
Abby developed an illness with a fever a few days before leaving Bamako for U.S. home leave. She went to her health unit, where she was evaluated with a rapid malaria test and a blood film, both of which were reported as negative. She was instructed to go to the hospital immediately if she had symptoms at home. She felt miserable from the time of her flight to arriving at home. She was diagnosed with malaria in a Tennessee emergency room, but because of her belief that malaria was a mild illness, refused hospital admission. Later that night, she developed breathing problems and was admitted directly to the intensive care unit. At admission, over 25% of Abby's red blood cells were infected with malaria parasites. She developed severe acute respiratory distress syndrome and was on mechanical ventilation for a week. At one point, even maximal efforts in the ICU were failing, and her family was warned that her death was imminent. With heroic ICU care and her underlying excellent physical condition, Abby survived, but not without developing complications that threatened her sight and nearly led to amputation of some of her fingers. Pressure sores from the tape holding her breathing tube in place led to skin breakdown, which has left her with a facial scar that still awaits plastic surgery.
Waking up and thinking that, okay, I have a gash on my face, I'm partially blind in one eye, and I might have part of my hand amputated. It's like, why didn't I just take the medication?
Some people have chosen not to use their chemoprophylaxis with the belief that they have developed immunity to malaria as a result of having been infected before. This is actually not true. In order to develop semi-immunity, a person needs to have been born in an area where malaria transmission occurs and to have had malaria repeatedly. Each one of those instances of malaria is associated with a probability of death or permanent disability. It's not a risk we'd be recommending that you take.
Many government employees have spent the majority of their careers, sometimes decades, living in malarious areas. They may have developed malaria once, twice, or even 3 times, and feel that, like the locals, they have developed partial immunity to malaria and will not become critically ill. The reality is that it takes at least 5 cases of malaria, often with prolonged periods of illness before treatment, to confer levels of partial immunity that are protective. Before reaching this level of immunity, hundreds of thousands of natives die of malaria. No American should rely on this to prevent serious illness or death.
When we were at graveside, Danielle's graveside, my father, who's a retired Army officer, his brother, my brother, who is former military, Danielle's father, who's former military, and myself, who are former military, stood at her graveside, prouder than any grandparents, parents, uncles, mother could be of her service. Very different from our service. And of course, we had to ask the question, why? My father is a 2-time Vietnam vet. Why he was standing on this side of the ground and a Peace Corps volunteer was going into the ground. In our hearts, though, we believe in public service. It's our family business. Danielle continued the legacy of our family, and we're very proud. We are heartbroken that she is no longer here to continue the work and on the path that we knew that she was on. But we know that she touched many people in her short 25 years. And unfortunately, in her death, a message and hopefully a cause and a difference will be made because of her death in the way that she died.
Before I ended up getting malaria, with the detachment, the Marines that I was with, we had a CrossFit thing that we were doing for PT, and we do that 3 times a week. We got the State Department people from the building to come and work with us. We even had the local guards doing it with us. And anybody that's ever done CrossFit, they know that it's really intense physical fitness. I would say that after the year that I was in Madagascar, I was probably at the best physical shape that I have ever been in my entire life. I was doing very well on all the physical fitness tests that we had. Then I got malaria and I was completely immobilized for about a little over 2 weeks. And even after those 2 weeks, I was still learning how to walk. I still usually had to take it extremely slow or needed help with walking around even sometimes. And since then, I've been doing what I can to get in shape and everything like that, but even still, after spending months of doing nothing, I mean, it takes a lot to get your body back into shape.
If I were to talk to anybody that was me before November 2013 or new in the job and did not realize the severity of malaria, just saying take your medication isn't enough. I think demonstrating the impact that it has on you, and for everybody had to find their motivation, right? And so for me, I'm very career driven and family oriented, which I'm sure most people are. And what were the 2 things that suffered here? One of the worst things that anybody can experience in the entire world is the loss of a child. My parents almost had that. And then for me, I mean, things are okay with my career, but it's not going in the trajectory that I thought it would, you know? And I've had to readjust a little bit. And it's, you do what you can, but nobody anticipates it. And if I could, of course, if I could do it all over again, I would take my medication. But if something was going to stop me, I always thought it was going to be something out of my control. What kills me on all this is that it was in my control. So that's why you should take your medication.
We hope what you have just watched will assist you in making decisions about malaria prevention for you and your family. The personal accounts from our colleagues demonstrate that malaria is not just the disease that kills locals and spares the Americans. And remember, these were just 3 of the 162 confirmed cases of malaria in Peace Corps and the State Department in 2013.
We recognize that government employees and volunteers assigned to live and work in malarious areas and take antimalarials for years have different concerns than the occasional traveler who may have meds recommended for just a few weeks. Worries about potential long-term side effects are frequently raised in our surveys. Placing your children or a pregnant woman on long-term chemoprophylaxis only compounds these concerns. We didn't include testimonials from State Department families whose children developed severe malaria or the woman who lost her pregnancy while in the ICU battling malaria, but these occurred in 2013 as well and demonstrate just how vulnerable children and pregnant women are to malaria. We ask that you consider the actual risk-benefit analysis as objectively as you can. Despite decades of use, there have not been significant long-term side effects seen in babies, children, or adults with any of the antimalarials that you will be prescribed. Contrast the rare occurrence of serious side effects potentially seen with any medication, including antimalarials, with the common severe illness, complications, and death seen with hundreds of thousands of malaria cases per year. The risk-benefit ratio analysis seems to strongly favor taking malaria chemoprophylaxis. Furthermore, when you are making these decisions for your children, consider the sobering fact that children under 3 years old are the most likely to die from malaria, and that an African child dies every minute from malaria.
Remember, when you and your family are heading to a malarious area, whether TDY for a few days or for an assignment for years, using these time-tested preventive measures will diminish your chances of being infected with malaria, as well as other insect-borne diseases such as yellow fever, dengue, chikungunya, and encephalitis. 1. Avoid being out during peak mosquito biting times at dusk and dawn. 2. Use personal protective measures such as wearing long sleeves and pants and using topical repellents to diminish biting. 3. Use insecticide-treated bed nets and clothing that repel and kill mosquitoes. 4. Take one of the recommended malaria chemoprophylactic drugs as prescribed before, during, and after your posting to a malarious area. 5. Seek prompt evaluation when fever, headache, body aches, or diarrhea occur while traveling or after returning. 6. If you develop an illness with a fever in the year after leaving the malaria zone, make sure your provider knows where you were and what antimalarials you were prescribed. This is important in considering whether malaria may be causing your symptoms. As you finish viewing this presentation, make sure to bring up questions and concerns with your medical provider. We want you to understand the risks of malaria and ensure that you make the best decisions in protecting yourself and your family.
Please keep in mind, we're sending you overseas to do a job. We need you to stay safe and healthy. We will provide you with the tools you need to prevent malaria. We rely on you to use them appropriately.